So we started out with this is for a prostate patient, and we want to justify, what margins to use for our prostate patients. So we started out with a population-based model, which everybody is aware of, an ERCS model, where we say that 95% of the treatment for 90% of the patients, assuming a setup error of plus minus 2 millimeters with the daily imaging system that we have, the orthogonal imaging system, using the VisiCause. And we assumed that the patient interfraction motion was about 2 millimeters. And then on the basis of this, we said, okay, the PTV margin of 4 millimeters and 6 millimeter cranial caudal would be sufficient. Now, the question is this an adequate margin? And how to identify the 10% of the patients with the larger interfraction motion. So we went through looking at this prostate motion study. And this is what we did. This goes back 2 years ago, where prostate treatment delivery, scheduling the patient in the room, in-room patient setup, organ motion, yes, motion monitoring, no, tumor regression, all that. So we monitored that for during first 10 days of treatment and performed an in-depth analysis of all of the imaging to determine whether we fall into that criteria of acceptability that we have established. So this was a study that was done right before the PT-COG last year, where 181 post-DIP images were looked at. And basically the bottom line of this was that we wanted to see if our margins that we were using were adequate, and we found that 5.5% of the image pairs were out of tolerance, and we expected 9%, so we felt fairly comfortable that that would be a good recipe for the margins for this particular disease site. And now the question is, do you use that for every patient? Can you use that as a population-based margin recipe? And the answer is most